Good morning. Welcome to Health IT. I know that there's been a lot of good presentations that were made, throughout the morning already. I was, just keying off of the last speaker who's talking about designing for data. And so this topic is about data and metadata. And you're going to probably say, depending on where your context is, from business or if you're in IT, it may mean different things to you. And part of the purpose of this panel is to add some clarity to it. And if we were to take on the task of designing a future IT architecture for data, what role does metadata have, and do I even have metadata if I have data? So we're going to go into a lot of those topics that have to do with how can I leverage cloud computing, what about security, what about contextual data versus policy-based data, and so forth. Who I am, I'm chairman of the SNIA. SNIA is an industry association focused on network storage and data management. We tend to get involved in policy-based metadata around intelligent storage systems, and so that's the role, and brought to you by us, and coffee's not by us, but that's why I'm up here as a moderator. What we have here across the our panelists here, we have a wide spectrum of folks that have been involved in the consulting industry, with probably over 100 years of expertise plus up here. Doesn't mean that we're aged like a dinosaur mainframe or whatever, but there's a lot of knowledge up here. So part of the aspect of this panel is your involvement at working with the panel and asking your questions. This isn't about me being smarter than a panelist or a panelist being smarter than you. It's about you getting some of your questions answered that maybe someone else on the other side of the room had the same question, but no question is not a stupid question. It's a question about adding clarity to how do we move forward as an industry, both as consultants, software industry, hardware industry, and all the practitioners all built up around the healthcare industry. So just briefly, I'm going to just introduce the names of the folks in the order that they're here, and then as we get into the first question, each panelist will elaborate a little bit more about their accomplishments in industry. First, we have Gary Barnett, who was on earlier today. He's with his own outfit out of the UK. Thanks for coming over here. I guess it's a global practice. That's why you're here in the States. Next, we have Bob Rogers, who's the Chief Technology Officer from Application Matrix. Next, we have Dave Diamond, who's the Chief Strategist of Health Sciences at EMC. And the last person on our stage here is Dan Hausman, who's the co-founder and managing director with Recombinant Data Corporation. So one way we talk this panelist is maybe introducing the subject. If you wanted to start off with your own definition of metadata, or what your elevator pitch is, if someone says, what is metadata and why should I care about it?
I guess I'll start off, and I start by saying that the one thing that we deal with all the time, because in our business we're in data warehousing in healthcare, scaling all the way from genomic information, which is sort of the more new emerging pieces, all the way to bread and butter pieces, just looking at how is my clinic doing, what's my practice operating on. We live in a world where one man's metadata is another man's data. And so if we ask someone when they're looking at genomic information, what's the metadata, that data actually is usually the information about the patient, which cascades down to what is the data when we're looking at the clinical data warehouse. But that being said, that the metadata we tend to focus heavily on, especially in data warehousing, is all of the operations we need to run the data warehouse. And so, much like a physical warehouse, you wouldn't be able to operate such an enterprise if we were shipping boxes and things around unless we knew where the boxes were, what was in the different types of boxes, what were people ordering, and all that kind of external content of what's going on in the system is all stored in different forms of metadata. So we live with technical metadata, business metadata, and process metadata, that if we don't have that catalog that allows us to view what's going on, the whole enterprise of trying to bring information together is somewhat useless. And so it becomes probably one of the key factors when we're building out systems to look at, what can we get from metadata? Because at the end of the day, we're gonna have someone who's looking at, say, a report or a view, and they're gonna have a question. Someone's calculated some clinical metric, how many patients we have who have an A1C greater than 9 in the past year, and they're gonna ask the question, how did you get that answer? And the how do we get that answer is basically that big pile of metadata that sits in the back end and says, how do we code things? How do we process the codes? What system did it come from? Where did we move things from system to system? And we're probably going to summarize it quite a bit for the end user physician. But as you go deeper and deeper to asking these questions, you get into more and more need for metadata. And that's why we put a lot of emphasis on it when we do the work we do.
Great, thank you, Dan. I think it gets harder as you go to the left, right? So I'm a strategist with EMC. You'd probably know us as Cloud, Big Data, and Trust. I hope you would, because that's what our market team would want you to know. Let's talk practically about it in the context of physical metadata and logical metadata. My focus is really getting out in front of what I call big data clubs. Big data clubs are when organizations across the industry, some of which compete with each other, actually see value in the magnetic attraction of data to one another. And that requires big data, and big data we describe as variety, velocity, volume, and when they come together you get complexity. So if we think about metadata and the physical aspects of metadata, you have the policies around it, as far as where it's stored, where it's been accessed. You have the provenance of it, the lineage of the data, which is very important to order the data and do analysis on it to visualize it and move it from visualization into process improvement. You've got the protection of the data. You've got the price of the data. You have related to the velocity of big data. You have the performance requirements, which is a real challenge. So a couple of use cases where this is important. We do have a boutique focus on medical imaging because we have a lot of volume in data centers that have EMC technology on medical imaging. There's a lot of very rich metadata in medical images, but it's not typically utilized. They're also very large files from a volume perspective, and with emerging use cases around telehealth and the distribution of medical services, you need to actually understand how that image has to flow, could flow, and you need to create more of an import-export kind of capability for the image as it goes through the cloud, ingress and egress. So we're working on some projects now where that metadata is starting to be analyzed as it's acquired and starting to look at all those Ps. That's one. The other one is really around a data club, and I guess the use case I'll use today is around medication compliance. This is one of those very magnetic opportunities because there's value for it in everyone in the value chain. The provider wins on it because the health status of the patient improves. They're trying to take on risk from payers. The payer wins because they're trying to reduce costs and incent changes in physician behavior. The employer or the patient or family wins because the health status improves. And big pharma and the PBMs win because their volume or their revenue could potentially go up. There's an opportunity to actually exchange data. It takes a cloud construct and it requires many of those Ps that we talked about. It also requires the association of, through metadata management, the association of various types of data, including a lot of, in big data, a lot of unstructured data that needs to be reduced for analysis. And so that's the area of focus and what I'd hope we could interact about today on the panel.
And I'm Bob Rogers, and I specialize in metadata as well. But from a systems management perspective, I chaired the Information Lifecycle Management Group at the Storage Networking Association for several years. And so the words that I've heard today are digital provenance and digital curation, understanding what that data means 50 or 100 years from now. And that's really the area of expertise that we're working on. So being able to understand where that spreadsheet came from, where the email came from, who touched it, what happened to it, and how it mutated over its lifetime is one of the things that we care about.
So my very quick definition of metadata is if data is the flat pack and information is the completed shells, metadata is the instructions on how to assemble the completed shells for my 30-second elevator pitch. I struggle at a much more prosaic level with clients and enterprise architects if something says it's in degrees, does it mean degrees Fahrenheit, degrees Celsius, which actually is quite important if you're boiling water, particularly if you're going to drop someone in it, or indeed if you're a spacecraft going to Mars, or indeed is it degrees of rotation and so on. So it's getting to grips with those basic things. So it's a combination of the tags you need to assign to pieces of data, but it's also the standards that we might apply. How should an age be expressed? What is a date? How should we express a date? Really tedious stuff like that. And a lot of my time is spent working with clients trying to figure out how to do the necessary translations so that when we take an image from 3 different sources or 3 different sets of data, that we know that when degrees is mentioned, we know what kind of degrees we're talking about, because that's what makes the data usable.
Okay. Well, historically, like you're starting to describe contextual use of the data. That, for example, degrees. And if you're trying to design a system for the future and unlock some of these siloed applications, what would you be looking to do in terms of getting an export of that metadata and creating something that could be very open to the organization, to different applications to work with that?
Well, I'm already doing this process with clients, and the answer is we do everything on the list, unfortunately. So we start by saying, well, we're going to express date and time using universal time and agree some standards. We're opting to go metric. Because even when even talking about gallons, the fine British imperial gallon is somewhat fatter and bigger than your puny American gallon, for example. So it's the best you can do is, if you're designing something new, is absolutely go for the current standards and don't backtrack because it's easy. To if the bulk of your data is in old-fashioned inches and miles, don't be tempted to adopt that as a standard, and then do the boring eating your greens type stuff about making sure that every piece of data that gets in is appropriately tagged. The other thing I would say is wherever you can use intelligence to infer tags, because much as we'd like people to dutifully tag every piece of data they add to a data set, oddly they don't. So if there's anything we can do to guide people, and a lot of that is about how we design the user interface and the process flows for things.
Wayne, if I can make a suggestion, anybody that has a question, just come walking up to the table here. They'll know you have a question, obviously, and you can ask it right from the mic. So please don't be bashful. Come on right up.
We know Jeff Early has some of his questions answered, but not all of them.
So the most common term we end up hearing when we ask the question, how do we standardize data, the term that pops up is data governance. And as a result, I mean, that's a vast term just like metadata, but I think that's where you start getting into the process of dealing with how do you standardize things, because you have to put in place the rules and the process and the people that are going to make sure that things can be operating in a specific way. And so usually at the start of any of these kinds of projects, you have to start looking at what's the current governance process in place and how can we move it to what we need to have things that are going to operate a little more standard, so we have a lot less of those people trying to do manual data entry, or we don't have to trust that cool algorithm that may be able to calculate that we're using British gallons or kilograms versus ounces. And then the secondary piece that we end up thinking about quite a bit is, what world are we really living in? And I bring it up philosophically because there are 2 camps we end up seeing. And this has been defined in sort of healthcare informatics and in other informatics groups, is there's the camp of the scruffies, people like me who have a beard and are kind of scraggly, and this sort of world of the neats, who want things to be all defined up front, perfectly entered into standards and built together. And there may be some middle ground. But for the most part, if you're dealing in secondary uses of data, you have to accept the world is the way it is and deal with it and transforming it and converting it, and you use governance to move it a little bit by adding stewards and people who can then impact how it's captured and how people interpret it and things like that.
Does anyone in the audience have a project that's going on that sounds like anything we're talking about? Does anyone work in IT in a healthcare organization? Are you all speakers and sponsors? Okay,
We're all publishers nowadays, aren't we, Wayne? When you come
yes.
up and ask a question, please say your name and your company also.
Keith Salzman, I'm with CACI, and we do systems integration for the Department of Defense and VA. So they have a big data problem to get their legacy EHRs to, first of all, communicate, but then building an integrated EHR for the future. And so when you're talking about semantics and data dictionaries, I know that you said you have the scruffy part out there, but unless you have a vision for where you're going, you're never going to incrementally get there. And in looking at the data structures, you can build a model that is reliant on a lot of translators, so that every vendor can put a translator for every EHR out there, or you can build a data structure that people have to speak to be able to be in that environment. And could you speak to that as far as a strategy?
I can talk a little about some practical work that we're doing now, which might lend itself to that, and then it's probably an area for you to comment on, Dan. But we have found that in focusing on healthcare delivery side and looking at the vast amount of disparate data or different structured data from different systems, like electronic health records and associate with unstructured data, we focus on data science and the acceleration of analytics by bringing data together in somewhat of a sandbox. And it's not big data, I guess I would call it wide data because it stretches across many systems and the volume isn't quite as high as big data. And then doing visualization on it, iterations and developing algorithms about very specific problems. I'll give you an example. In a large provider network, let's say it's a $5 billion provider network, they have probably 20 to 25% of their volume, and sometimes their revenue is related to readmissions and hospital-acquired conditions, which increase the complexity of the patient's illness and increase their length of stay. And coming up very quickly, the hospital will not be paid for those things. So even though they have same-store sales with those types of things, the revenue can stay up, but their margins will dramatically decrease. Being able to get a handle on that problem and to be able to target around something like congestive heart failure, which is one of the biggest causes of readmissions, or looking at something like detection and intervention of diabetes or complexity related to diabetes, you can't get there in a four-stage approach, which would include data governance and data quality initiatives. There's not enough time out there with a business model shift. So what we focus on is bringing the data together, bringing in data scientists, and to help them understand and visualize the value of the data as it comes together. And that's where we see a lot of interest in the lack of quality of the data and the demand for more quality data, and that's where data governance starts to come together. In the setting that you have, which is so large, there probably needs to be a way of bringing the data together and then continuously extracting the data in a way. And I'm going to hand the mic to Dan because he probably has a real practical example on this.
Well, I think when you're dealing with the DoD and the VA, it is unique. Of the few health systems we can talk about in the United States, it's unique in that it's so vast and has the potential to standardize. And as you know, there's projects out there like OSERA to try and bring together these systems into a single enterprise and various different talks about how to make that work. Obviously, eventually you need some enterprise terminology function, which folks at, say, at Partners in Boston, we did a little bit of work with them on that to build out enterprise terminology, because terminologies themselves can become a service inside of an architecture. I think it's a little too forward-thinking today to consider that healthcare will converge upon a single data model for electronic medical record systems. If you look at the competitors out there, Cerner and Epic, they're doing so well because the government is funded through meaningful use. The huge proliferation of these systems, they're not about to standardize anytime soon, and they're not about to merge anytime soon on a coherent model.
What I would say is Kodak is the same way.
Yeah, well, I mean, yeah, and Kodak fell down at some point. But we can't really predict what's going to happen with those big players. But I'd say the things they can standardize on are They can standardize on conceptual terminologies. They can definitely use interoperability platforms to standardize. So the things that are out there, like the health information exchange formats, those types of initiatives do create a forced standard inside of the systems because they need interoperability. And maybe the last thing I'd say is there are some initiatives that are trying to force everyone's hand, like the project out of Harvard that was funded by the government as part of the SMART initiative, where they're focused on a middleware tier, which will allow you to work like Java to talk to your EMR or other application that has a profile of an EMR in an application box as though it was fungible. And so this SMART platform project could be useful provided that it can be allowed the airtime to breathe and live. But it's going to end up competing with the selfish interests of the various EMR companies who don't want middleware running on top of them to be able to build fungible applications. So I would recommend and hope that the VA and the DoD could help sort of build an enclave for tools like that to get applications built that could then be ported into these more proprietary systems.
Did you want to comment at all about any of the physical aspects of the metadata that has to deal with how long does your project, you have to store your data, how well does it have to be protected, where does it have to be stored, who's allowed to modify it, and so forth?
Yeah, the data has to be stored for 70 years for a patient, so that's quite a while. And then the interoperability as far as the metadata, those are things that we did with, and that's why I think the DoD and VA, despite their warts, have really pioneered interoperability, and they're moving on to the next generation, which is integration. And I think that that's something that, like Kaiser with Epic, they have however many implementations of Epic that don't talk to each other. So failing to deal with that because of selfish reasons for corporate profits and things like that, instead of looking at the writing on the wall and seeing that we have a healthcare budget limit, which is our, the debt that we're accumulating, and that should drive us to start looking at the national self-interest and collaborating and cooperating to get to interoperability and integration of systems. And then we've talked about it a little bit offline, but the innovator's prescription really kind of fleshes out what the challenge is to healthcare as far as transformation and getting to where the financial industry is now. A lot of the industries that have taken challenges to transform, the challenges healthcare face are bigger, but they're not insoluble, and we really have to, I think, roll up our sleeves to start doing that together.
I'd encourage you to set the bar higher than the financial services industry when it comes to standardization of metadata. Bless them. Their challenge isn't on the same scale as yours, but they've got an awful lot to do as well.
Yeah.
I would say that the healthcare industry has some extra problems, and I know the financial industry is regulated in various different ways, but because the healthcare industry, we don't live in a world with nationalized healthcare, we live in a world with heavy regulations around the portability of healthcare data, heavy regulations on the storage of healthcare data through HIPAA. And certainly in our world, when we're dealing with metadata, if we go back to that topic, it's a huge topic to understand, are we complying or not? And we need reams of extra work to put in place to determine if we're complying or not. And I think it creates to what would be a place where you could have a lot of innovation, a lot of blockers to innovation, because we can spend, and back to this governance problem, we can spend months deciding if we can even do something innovative and still be compliant with HIPAA and still be compliant with the common rule in research, which says, we can't even move a patient's record without consent. And so I think there are some consents in financial data, but they're a lot different from the ones we deal with. And there's going to have to be a little bit more done if we want to revolutionize how healthcare IT works than just a little bit of payment reform. And I'm not saying we need to get to a single healthcare system, but we certainly have to change some of our notions of privacy.
And one comment, what other industry has hundreds or thousands of independent providers that need to share that information and secure that information. The financial industry doesn't even come close. I do have a question, though. How many people in the room here are involved in doing migrations from one EHR system to another? Because that seems to be a topic that's come up. Several people.
We have someone that's not a sponsor or a speaker. We saw in back there. Okay, we have another question that's teed up.
Yeah, Seth Early from Early and Associates. I understand that health information exchanges are mostly standardizing on structured information such as lab results. What about unstructured information in EHRs, and what needs to be done to text mine that data and gather more insights from that kind of source of information rather than the structured information that we're seeing around things like lab results?
I can speak a little to that. So I think, let me just back up, because the example of the multiple installs of Epic not talking to each other with meaningful use, the round 2 of meaningful use coming out, there is this requirement to exchange data in a meaningful way, and that's, across healthcare enterprises. There's a very good set of standards that's been out there for 5-6 years for cross-document sharing of scanned documents, images, and to the ability to actually plug into a socket around a process socket, which is like an audit trail for where the data has been and where it's going. So you can, go into multiple Epic systems or multiple integrated environments with CERN or Epic and many other systems, in a sense, jack those systems up at the integration layer, define the actors and transactions, and orchestrate those to create an integration fabric. Now, on top of that integration fabric, that's a prerequisite. Then you need to build more of a data fabric on top of that. And that we haven't seen a lot of that happening. There are a few very boutique, unique kind of companies. If you went to the HIMSS conference, you might have bumped into them, that are actually search technologies that will rip through unstructured data. They'll associate it with not a data structure of Epic per se, but in how organizations are extracting data from Epic and reporting on it, and in a sense putting it back and evolving that reporting and curating it in a way. And they're actually allowing you to pull up an electronic medical record, to use an open API for that that's open for context management, and then pull the data in across the healthcare system or request it at the border with a continuity care document, continuity care request. It's very preliminary stuff. To really get down to the, to focus on the big challenge, the electronic health record vendors are going after composite play. They want to do a staged implementation of all their modules, all their systems, and they want to become evidence-based medicine companies, not technology companies. And so there really isn't a reason for them to really want to interoperate at the data level. So to really answer your question, it's just starting, it's just beginning, but look to the standards of health information exchange. Cross-community exchange is probably the one you want to look at for getting that data piped in.
Well, we certainly have tried to use narrative text in productive ways beyond what the standard of practice is today. But we do run into real issues. So for example, if you're a doctor who's practicing and a computer says, I've analyzed all your notes and this patient has these 3 diseases, that's a problem. You never documented that these diseases were on this patient's record, and this computer is not yet trustworthy enough to be considered your peer. And when we start doing this at a high scale, we run into the risk that we're going to be creating clinical decision support that's flawed. And EMRs already are not regulated systems like a device, and a clinical decision support system becomes like a device. And so if we really want to have an impact doing all this text mining, eventually we're going to have to get to the point to which it's useful in the context of patient care, not just in looking at big analytics. So today, we can do some analytics. We can do the kind of thing we ended up doing at one of the health systems we're working at, where we had 60% of the blood pressure readings, and we wanted to get to 80% of the blood pressure readings by pulling out the blood pressure readings from the free text, because that's the way they ended up being documented. But that's not earth-shattering stuff. And I think we're going to have to be crawling a bit before we can move forwards. But it's also been documented. If you were to run the records through, Adam Wright from Partners Healthcare published this on all of the free text notes versus the documented problem lists, you can enrich the problem list by 30 problems per patient. but no one's ready to accept those problems.
Do tools like IBM's Watson system have any promise in that space, would you say?
I think you can comment on that. Probably better than me.
I'd say they have fantastic promise, but socially we're not ready for them.
Great,
Right?
thank you.
So I think that we'll eventually get to, I mean, Zach Kahani from Partners published a paper a while back talking about, what is a doctor really going to do in the future? Right? Is it eventually going to be moving towards a situation where it's more like a McDonald's, person who's publishing a button saying, this person needs a hamburger, because the medicine's going to get more complex as we can pull in all sorts of markers that the doctor can't see from their genomic information. We already have plenty they can't see from their blood tests and their labs, and no doctor's capable of even interpreting whatever we think the future of the input's going to be. And so we're going to be moving probably towards a lot more recommendations from our friends like Watson. And we're going to have to look at systems where they're part of the picture. That the doctor's role is to use these kinds of tools. Now, the vision of Watson was sort of to replace House. For those of you who have read the books on Watson, they're like, well, what we really want to build is something that can deal with complex diagnoses where we can't figure out why this person's in here and suddenly magically read through reams of data that only a Jeopardy scholar would get. And that might be a great use case. I'm skeptical that the computer's going to do this, and that House, actually, that guy with the cane, really wants that. And will even listen to the computer and not throw it out after 3 tries when it's wrong. But great promise, I think, from these technologies, and that's what's fun for us, when we can get to the computer's doing part of what a doctor can do. But it's going to be a while, and we've been beaten up enough times that we're cautious.
Thank you.
I had a quick comment on that too, and I think it lends itself to the archiving of data and why you want to archive data for more than 7 years and understand the lineage of that data. If you go back and look at the promise of Watson and think about the Institute for Healthcare Improvement and their idea of a global trigger system around patient safety, that's a real world need in the market. The other side of that is the alert fatigue which care workers have when placing orders and moving through the transitions of care. So it has to be trusted. I think it has to be tied towards real-world implementations. And from a cloud perspective, it really is complex event processing like we see in other industries, like bond traders have. And there's a whole lot of technology and underpinnings for that just aren't prevalent in healthcare yet. So I think it's a ways away, and I also believe it's shifted quite a bit since accountable care as a business model has come out. There's more interest in it.
And just one other comment, it was just in the last 2 weeks that the litigation system began to use electronics to go through and search for information that could be used to support e-discovery. So if you think about what's happening on the litigation side, you can easily expect that that'll happen on the diagnostic side as well.
Say something briefly, not in defence of Watson, but to fill out slightly something. Certainly in the domain of research, the problem is the structured data contains all the stuff we already know is important, and research is about finding the new flags, the new things, and because they haven't been discovered yet, we can't build them into our meta models. So the ability to do, and Watson doesn't have enough arrogance to suggest that patient has Y. Watson says I think patient is most likely to have Y. Technologies like Watson that can do a scanning across a very, very large set of data, and Watson is containing an awful lot of, runs an awful lot of knowledge in memory, are going to be a really important additional tool, but I'd certainly agree, I don't perceive it as a replacement to the doc.
And I think also Watson's a very specific type of technology for processing free text questions and answers. If I look at what they were doing on this rheumatoid arthritis study they were doing, trying to understand so that they could calculate what's going on in terms of drug treatment for rheumatoid arthritis. They have the full medical record, they have the full notes, and guess what? No one has any idea why a patient was switched from therapy A to therapy B, because it's very complicated. There's all sorts of new therapies that are coming out in the last 5 years. Maybe they switched because they wanted to try a new therapy. Maybe they switched because the old therapy wasn't working. Why wasn't the old therapy working? It's all in the notes somewhere. But the only way they got anywhere was by overpowering it with experts who sat there and read through a sample set of the notes and tried to annotate what do these things mean in terms of when someone says patient is not responding, patient is having erosions. It's just very hard to replace the expert in these kinds of systems, and I expect that for quite a while we're going to have a lot of training of the computer if we want to scale up these kinds of assertions.
Another question from the floor?
Yes, Data Silence with First Medical Solutions. One question for the panel. Who owns the data? Who should be responsible for the data, and who should manage the data?
You're not expecting those all to be one person, are you? No, that's good news. In the UK, there is very much a sense that the National Health Service owns your data. It's actually very hard to get your own medical records. You have to ask very nicely. My personal belief is that I should own my medical data and then I should control access to it. But someone else needs to be responsible for managing that access to it. The reality is all of the above plus nobody, in practice.
I have a very precise answer, and it's the patient. The patient is and can be the steward of the data. They can curate the data. The data follows them. If it belongs in the health system, not every patient goes to the same health system or receives the same provider, and statewide exchange and interconnectivity isn't there. And even then, the data isn't going to particularly be everything that's needed. So we see a movement, and EMC is kind of a testament to this, where there's the payers, those who pay for care, are actually getting behind kind of the next generation of the smart PHR, where there's repositories out there where data can be stored. They're trusted public cloud type of technologies. EMC, all of their employees deposit their healthcare information, payer data, provider data, comes from PBMs, labs, and it gets to put into a repository. It goes through a portal. There's apps to get at it, and you can come to your physician and actually give them a PIN, and they can view the data. But it's all there, and it's not just snapshots from providers. The payer data, the whole claim stream is there, and like I said, we get medication alerts in our email. So we're very mature in that area.
Dave, I'm glad that you clarified what you said, because I started out agreeing with you and then said, no, you're wrong, okay, and then said, yes, you're right.
Oh, thank you.
Because I agree, the patient does own the data, but the patient is not necessarily the custodian of that data.
Got it. I would agree.
So when we talk about ownership, we're talking about law, and that means we have to go back to HIPAA and other things. And technically, a health system owns its data. Whether the patient philosophically owns its data, the patient definitely owns the consent process about the data. But if a health system has to do operations functions as owners of this asset, which is a disk drive of all the patient's data, they're allowed to do what needs to be done with that asset that they have that they own. There's issues when they want to sell the data. So the question of ownership is, it's not a portable asset, right? They can't go around and sell your data to anybody. They can actually sell your data. GE sort of has a copy of data that ends up slowly into the hands of pharmaceutical companies. Ingenix does the same thing by doing de-identification. And so when your data becomes not personally identifiable, it becomes an asset that's portable, except for one new rule that high tech added, which means they can't profit beyond the amount it costs to generate it. And so I'd say there's a strong indication that the health system does own the data, but that they can't just do what they want to sell it. And personally, I'm not sure I like this limitation about how much they can profit from a patient's data once de-identified in other cases, because in the finance industry, there's plenty of derivatives of data. And so if you want to go back to your innovator's prescription or other areas, there's not much we can do, sorry, right? We can't aggregate a whole bunch of data and figure out how to make healthcare better. It's just too complicated, it's illegal, and sorry, it's just going to continue to be terrible. So it creates issues. And I think some of the balances here are just privacy versus innovation. And I'm not pushing that we should not have privacy, but I think we have to be careful that if we demand both, we can't have both.
We tend to be like a rather mobile global population, and you know, some of these answers were very grounded in what geopolitical area that you're living in. And I was wondering if you want to make any comments that when people are moving between geopolitical areas and some of the third world, and where it may not have the same IT, if you own your own data, or you can mandate that it be transferred, and then how does it continue to be augmented and then come back in? So say you take a temporary assignment for 6 years in Nigeria because you're an oil field worker working for Shell coming out of Houston, and then you come back. How would you expect to see that work?
I can speak to that from personal experience. Firstly, in the UK, if you're pregnant, you carry your own patient records with you, because that's the only way to integrate them. Yeah, there's no other way. So you have a little folder that contains all of the information relating to the health of your unborn child, and you carry it. That's bio-integration. I've lived in a couple of countries, and certainly in the context of the UK, it's a wonderfully simple process. I arrive in America, I go and see my GP. He writes a nice paper letter to my UK GP, who photocopies my medical record, pops it in a little envelope, and sends it over. Easy peasy. Not a particularly efficient way to do things, mind you, but that's essentially how it's supported in the UK at the moment.
I can just give you an answer. I'm going to be traveling to EMEA next quarter, and you know, if I were to get you know, catastrophically ill or even just go into a hospital, one of the capabilities we do have as EMC employees, it's the same kind of thing as you have, for instance, with your 401k. You can just go onto the web and get it. And with EMC, we can give a PIN to any provider. If you go into my electronic health record, it has all my conditions, alerts and conditions related to medication and things along that lines. It has all my medical records in there, depending on which provider I go to. It has images in there, even my genomics profiles up there. So, you know, depending on how much you want to curate your own data and provide access to it, that's kind of the patient as the owner, patient as the steward of healthcare data. A very practical example, though, is I was on vacation and I had, you know, an ear infection and you know, a throat infection, and I took a camera phone picture and sent it to my physician through a secure text gateway. So I think we'll start to see more of this. Got an app for that type of approach to sharing information inbound, and you know, Teladoc is one, America Well, a lot of these anywhere, anytime types of encounters through the web.
You've got to stay conscious long enough to tell the French doctor, my PIN
well,
is
I got I carry a little pocket and a little thing in my pocket that, you know, that I can do it, or you can put the little mini CD in your pocket if you wanted to. That's pretty extreme, but depending on where you're going, it's probably not a bad idea.
I guess, you know, one part of the problem I was laying out there is that when you're in this other geography, how does your record automatically get updated with new test results if those healthcare systems aren't tied in with the ones that your base system is?
Yeah, I mean, I think it's going to be a long time before that problem's solved. And there are the two camps. The ideal camp is the one Dave described, maybe not employer-driven, but maybe employer-driven is the right answer, such that the personal health record is the way in which the patient can take control of their records. And certainly, all the infrastructure is in place to do it. You have CCDs, you have personal health records. Every single EMR now through meaningful use is forced to be able to produce your health record on request. Identity management still have problems because you don't really know this is Dave asking for his own medical record. They'll work on that. That'll get solved. The problem we're facing with personal health records is Google Health went bankrupt and decided to shut it down, which is that patients don't do this. And so we now have to go to plan B, which is if a patient isn't going to be as active as Dave is to take a photograph of his throat and text it, what do we do with the rest of the patients who aren't in that world? And we do have the sort of NHIN global type picture of the HIEs, which if we wait long enough, I think might form a realistic picture for how to get these things done. But the patient would be a much better route because the best way to identify that you're allowed to see something and do something would be the patient themselves. And so maybe something in between a PHR and NHIN will merge together. If you start talking to people trying to deploy these things, nobody can tell the difference. What's the difference in a PHR and an HIE? I don't know. Right? Patient has to consent to either. We're shipping the patient's data to somewhere. And so we'll just have to see how that plays out. And if it's global, it's great.
Okay. So we're going to just we're going to close off our panel and give each panelist one opportunity to say what would be the takeaway you would want everyone here to walk away with that said before you came here you learned something about metadata. What would you want them to do different tomorrow to advance what they're trying to do for their company?
Oh, great! I didn't know I was gonna
Yeah, that's a nice open-ended one.
I'll go first.
I'll write you a big check. No, it doesn't have to be that.
So hopefully I made 2 points. One is that you really have to stay out in front and try to think what happens on the next frontier. And to do that, you have to consider value exchanges. A value exchange like the two that I cited are things you've seen in other industries. They allow data to come together magnetically. I get a $2 rebate at CVS when I use my CVS card because I spent $50 and they've watched everything I've done over the last 3 years. I give them my phone number and think nothing of it. So many of these things have happened in the past. If you look at financial data, there's plenty of value exchange, secondary use of data. And so if you consider those things and consider that magnetic attraction, you have to go to where the value is. The other point I was hoping to make, and I'm not sure if I made it or not, is that we own our patient data. It can be deposited, even if Google Health failed because it required you to go in and actually do stuff and enter your own data. If you think of a model like mint.com, where you can actually give them your passwords to all your portals and it brings the data to you, it curates the data, it compares it, it analyzes metadata that's curated by other individuals and adds value to your financial data and then sends you an email with updates whenever you want. That's very helpful and useful to me. I think that's really the future, is that your data can go to separate repositories and come to you when you want it and how you want it.
I think the problem that needs to be solved yet is the taxonomy approach to being able to communicate with one another in terms of the medical records. That's going to be a prevailing problem for many years yet, but until that gets solved, I think it's probably going to impede progress on a fairly large scale.
For me, it's don't assume any of these problems are going to be solved. Expect them not to be solved. There is going to be no single source of your data. Expect it to be federated. There is going to be no single metadata or data structure that is, ordained for every piece of useful data. Expect that there'll be some munging and some integration that has to be done. For goodness sakes, don't ever sort of go, we're done now, because you're not.
I guess when I think about metadata, at least from the context of the panel we've had today, it's that you're going to have to do a lot of things with metadata because of the current environment we're working in. We have to do a lot with metadata to manage compliance with HIPAA, compliance with meaningful use, data exchange formats, management of information. And it should be an opportunity to be competitive. And you should go way beyond what is the baseline requirement, because if you look at metadata just as a requirement to execute compliance, you're losing a huge opportunity to be more competitive and probably to treat patients better.
All right, thank you all for your time, and thanks to panelists.
Great. Dan, David, Robert, Gary, Wayne, thank you.